Hello.
Hello, good evening.
Hello. Ciao Emilio. Ciao Bambini. Ciao Sebbi.
Hi guys. Hello everybody.
Guys.
Welcome to the episode number 8 of Dermoscopy Happy Hour.
It means 2 months in which every Sunday we were with us. Can you imagine? You know?
Yeah, it's nice.
Drinking
I like
a
it.
little bit of beer and sharing a little bit of philosophic thoughts about dermoscopy.
Yeah, I don't like this point about the beer, but okay, we will discuss it between us.
No, listen, Emilio, Sebbi, can you show your face, please? Because I want just to take just 1 minute today, because I want really to dedicate this episode to a friend of us, a dermatologist. He was actually with us on Saturday, last Saturday, not yesterday, but 1 week ago at the workshop in Roma, where you also been, Emilio. And on Monday, he died. So 2 days after being with us, he died. And it was really something, let's say, very violent. So I want really to make a thought. And I suppose that some of the people connected here, I suppose they knew Federico. So this episode is for him.
Sure, absolutely.
Okay, now.
Thank you for your words.
Okay. So, Emilio, we have plenty of things to do today, right?
We have plenty of things to do, and we have new things. We have a little bit changed the structure. We have mainly because we have a new stuff to present, which is some of the cases submitted by the participants that today we will discuss shortly. And for this reason, we will start directly by inviting on stage, on camera, our guest of the day. And we will do the discussion of the paper of the week and the cases of the week together with our guest. And the guest of today is the one and only who?
Nisa
Let her appear on the screen. Here she is, Nisa, our dear Nisa Akay. Nisa is, I guess that you know her pretty well. Hi, Nisa, welcome.
Hi, Aimilios. Hi, Geppi.
How are you?
Thank you. Great. And you? You look perfect as
wonderful.
Sunday. I'm a great fan of you. Every Sunday, I'm here with you.
Yeah, and we thank you very much. So, Nisa, I guess you know her, but anyhow, let me say just a couple of words. She's a professor of dermatology in Ankara, in Turkey. She's a great researcher, published several papers, a great teacher on dermoscopy, doing a lot of things in her country and internationally. Also, she is in charge of the most successful group in Facebook with dermoscopy cases, the official forum of the IDS, which is the Dermatoscopy group in Facebook. And recently, I have the honor that she is a member of the executive board of the International Dermoscopy Society, in charge, together with Konstantinos Liopiris, in charge of the website and the social media accounts of the IDS. Probably already you realized that there was something new in our social accounts, something really fresh and active on Instagram, but also on Twitter and Facebook. And this is thanks to you, Nisa, and thanks to Konstantinos, of course. So you do a lot of things. How do you find time for all this stuff?
Indeed. First of all, I would like to thank you for your words. I'm really very honored, Aimilios. It's so nice to hear these words from you. I love teaching. I love dermatoscopy. So it's not difficult for me to find time for dermatoscopy. It's a way of life for me.
Of course. I mean, because as all the people, all colleagues dealing with dermoscopy, applying dermoscopy in the routine, we are passionate people, right? So it's not really as we work. It's just something like fun, you know? So
exactly. Like watching cinema or something else. I enjoy dermatoscopy.
Very good. But Emilio, what kind of paper did you select for the discussion today?
So the paper of the week, which is of course related to our guest, it is one of the many papers that our guest wrote. And the question is, can you guess, Geppi, from which journal will be the paper of this week?
I don't know. Maybe it could be Dermatology Practical and Conceptual.
Oh, you are so good. You are so good. But first, maybe you go with the question of the week and
question of the week. Exactly.
Question of the week.
Exactly. Sebi, let's go with the question of the week. Okay, so the question of the week is very simple. Do you remove Nevi with laser or other physical treatments? And of course, the possibilities are yes, no, sometimes. we love sometimes, you know. So it's a very philosophical.
Balanced answers are always politically correct answers.
Yes.
Balance, not being very, strong.
Yeah. Okay, so we have a great majority saying no. Okay, sometimes was voted by 28%. And yes, let's say 10. Okay, 10, 11. So, so probably the paper you're going to comment is on this topic or similar topic?
Very similar, of course, very, very similar. So let's go, let's start. I will share my screen as soon as Sebastiano allows me to share my screen. Okay, great. Of course, I forgot. We have an intro for the paper of the week. And there we go. So here we are. First, let me remind that in the end, we will play via Kahoot as every week, but we will come back there later. You can already, by the way, join the website and register in the game, but if not, you can do it afterwards. So the paper of the week for this week comes, as Geppi predicted correctly, from Dermatology Practical and Conceptual, which is the official journal of the International Dermoscopy Society, and is this one. So accelerated use of non-surgical techniques for Nevi removal, primum non nocere. This is Latin. Geppi, what does it mean? Primum non.
This is a very, very basic principle of any doctor dealing with patients. So first of all, we should not, let's say, give a kind of healing, a kind of problems to the patient. So primum non nocere means, first of all, we should not harm the patient. Yeah.
And this is Latin.
Yes.
Yeah. So it was not Greek initially.
Hey, come on.
Of course it was. I will show you later.
One of the very, very rare occasions in which we use Latin instead of Greek.
Yeah, but it was a copy from Greek. I will show you. So, but first, before I present you the paper, I want to play a little bit with you. So, this is a lady coming in our setting, asking for a young lady, as you can see, very much interested with her, appearance, asking for a removal of this lesion, which you can see here clinically, and you also can see here dermatoscopically. So now, Geppi, I would like to ask you to help me playing a little bit the role. So I would like to ask you just to play the role of the patient. So just please read what the patient says,
Okay.
and I will read my responses. Okay?
Please, doctor, I want it out. It is ugly.
Okay.
But no scar, right?
Well, a small scar is inevitable.
But you removed the nevus from my mother with a laser and no scar.
Me? No way. But then I check. And she's correct. She's correct.
Okay.
She's correct. This is the mother. This is the lesion that I removed with a laser and no scar. And then I continue the dialogue saying, okay, now I understand. This was a seborrheic keratosis.
What is this?
Well, it's something purely benign.
Mine is not completely benign?
Okay, now I ask now the assistance of the audience. Can we poll the question, Seppi?
Yeah.
So can we poll the question after all this dialogue?
What do you do next?
So what do you do now? Continue the discussion to convince the patient that nevus should not be removed, and so and seborrheic keratosis is another thing. But it doesn't mean that the nevus is not benign, and all the things that you have to explain. Or apply laser to the lesion and finish the discussion, or send the patient to Professor Antenziano, who is an expert with this stuff, and he can deal with the patient much better than
we have a name for this. Yeah, we call it Protocol 4. When you have a patient which is really difficult to manage, we say to the patient, go to this particular doctor who is specialized for your specific problem.
Exactly. Okay, so you see how many votes you get? You see how many votes?
A lot. Yeah.
By the way, that's a great idea. I mean, for this patient, but I would say that yes, theoretically, the most correct answer should be that we should continue the discussion and convince the patient. Okay, good. Let's close the result, Seppi, so that I move on with Nisa's paper, Nisa and her collaborators, of course, in dermatology practical and conceptual. So in fact, this is a presentation of 4 cases, of 4 unpleasant, unlucky cases of melanomas that were treated with a non-ablative treatment and without histopathologic examination. And then there was, as usually, a tragic continuum of the story. This is the first one, and unfortunately, it's just an 18-year-old girl that was referred to a dermatologist because of this lesion that you can see here. And the story was that 2 years earlier, a laser was performed for cosmetic reasons, and of course, the lesion then enlarged. And then when the patient went to the doctor, he thought obviously that this was a hypertrophic scar because of the previous treatment. So he tried to treat it with intralesional steroids and induce atrophy to the scar. Of course, it didn't work. And finally, the lesion was eventually excised, and it was a 7.8 millimeter thick melanoma. So that's the first case of the paper. The second case, there's no photograph, but it was a case of a patient with metastatic melanoma of unknown primary. But in fact, probably the primary was not unknown. The primary was known because a surgeon removed the lesion, I don't know how long earlier.
The neck.
Yeah. Removed the lesion on his neck for cosmetic reasons without sending the specimen for histopathologic examination. And of course, then the patient developed metastatic melanoma. Case number 3, quite impressive, 33-year-old woman that decided to went to a pharmacy for the mole that she had. And the pharmacy decided to suggest an acidic peeling to remove or destroy the pigmented area. Brilliant. But of course, after 3 months, the lesion started to evolve and expand, and this was a 0.75. Thank God that it was 0.75. And finally, case 4, again, we don't have the photograph of the lesion, but we have the photograph, we have the MRI, the magnetic resonance showing the brain metastasis in a patient that previously he removed the nevus on his leg 3 years ago, but it was again not histopathologically confirmed. So with these examples, Nisa and her collaborators conclude that this is a very worrisome situation. This habit to remove for cosmetic purposes lesions for which there is in fact diagnostic doubt. And as physicians, we should always remember that the famous Latin phrase, first don't harm. But now I will show you, Nisa, that this was a mistake in your paper. This is not a Latin phrase. This is not a Latin phrase. I don't know if you ever saw this movie. If you didn't, you have to do it. It's a very nice comedy, My Big Fat Greek Wedding. And this is the father of the bride, who was Greek and who was trying to convince everybody that everything originates from Greek. Everything.
Everything.
The point is that
by the way, that everything could be cured with this liquid.
Windex. The point is that he was correct, not about Windex, about that everything it comes from Greek. In fact, this was one of the 3 main points. This is one of the 3 main points of the Hippocratic corpus, which, by the way, says so nice things. If we want just to take a look and remember that our first goal as clinicians is to respect the teachers that made us good clinicians. The second is to transmit our knowledge, so we don't have it, our knowledge, for ourselves. We have to share it and transmit to others. And finally, of course, to use all we know and all we can to help our patients, or at least not to harm them. So nice words, so many thousand years ago. So that was it. This was the paper. And of course, there is quite a lot of discussion here. Nisa?
Yeah.
Would you like to make an initial comment, and then we can...
Aimilios, indeed, you talk about everything, what I want to say. The message should be, from my point of view, from the exact point of view. I mean, nothing. If you think about the melanocytic lesion, you should excise it and send the specimen to histopathology, because even very experienced dermatoscopists can have some false thoughts about the lesion. For example, I have many melanomas. The size is around 2 millimeter or 3 millimeter. They look very, they are looking like benign nevus. But at the follow-ups, I see changes and excise the lesions and see that they are melanoma. So for not to skip a melanoma, we should either follow up the lesion or excise it and send the specimen to histopathology. We should never perform laser, cryotherapy, electrocauterization, acidic solutions on the nevus, on the melanocytic lesions. And the other aspect of this, for example, the lesion can be a nevus, but after the laser therapy, if the nevus is a vernal nevus, the melanocytic cells, the remnants of melanocytic cells stay at the deeper layers. So we don't know the laser lights induce malignant transformation for further processes. For example, maybe in 2 or 3 years, these remnants of melanocytic lesions can turn into malignant transformation. We don't know this. For example, if we have a look at acral melanomas, patients generally said that there's a trauma here, a nail or something else. So, for example, after a burn scar, a melanoma can rarely exist. Or after a radiotherapy, a melanoma can exist. So we don't know laser will induce changes like this in the later years. So we shouldn't perform laser lights over the surface of the melanocytic lesions?
Well, of course, the transformation can happen, but the actual problem is the underestimation of a melanoma, which is already there. Yeah. And then you burn it out, and of course, everything goes into hell. Sure. That's basically the problem, because in many instances, for example, for an intradermal nevus, come on, it's not an obligation to make an elliptic excision. We can do a shaving, but the most important thing is that we have to send the part that we are going to shave to the pathologist. That's very easy. And then we have a very good scar at the end. And if the pathologist confirms that this is just a dermal nevus, the chance that let's say the remaining part of the nevus could develop into melanoma is more or less the same as, so it's 1 out of 200,000 chance to develop melanoma, as is the case for a regular dermal nevus that you don't treat.
And so, anyhow, a shave excision is not a destructive method. The shave excision in the worst scenario might be incomplete.
Well, but at the end, what is remaining there, you make a little bit of electrocoagulation or laser or whatever to have a more a better scarring. Anyway, in my view, it's not really necessary to change completely our mind. But the most important thing is really just come on, send the specimen to the pathologist. This could be the message, in my view.
There is, by the way, a comment, but it's very similar to what you said. It's by Zoe, that for dermal nevi, precisely what you said. You can perform a shave and send the specimen to the pathologist. There is also another question. When you don't see any suspicious pattern in dermoscopy and you are almost 100% sure it's benign, you still recommend surgical removal always? Well, no, this is not the case. I mean, I showed you the seborrheic keratosis that, of course, in the mother of the girl, that, of course, we treated with, don't remember, laser or cryotherapy. Nisa spoke about melanocytic lesions. So when your diagnosis is Nevus, your clinical and dermatoscopic diagnosis is Nevus, then it's important to have an histopathologic confirmation.
There is also another question which is related, by the way, with the cases I prepared. When we talk about laser, are we including air removal lasers? Can I show you my cases for a moment?
Sure. Show your cases and we discuss everything together. Yeah.
Yes, exactly. So can you see them? Yeah. So this is a very young gentleman. And as you can see, there are very few, a certain number of small melanocytic nevi, as you can see here. But when we applied dermoscopy, that's the situation. So what do you think is going on here? Emilia, Nisa, what do you think?
The destruction of the melanocytic cells with the laser light.
Exactly. So he performed a laser treatment for hair removal, and this is what happened on his pre-existing nevi. So of course, I mean, in the great majority of cases, nothing is happening. But I really don't like my nevi appearing like this, in some way, so it's really, it's something which is disturbing me, even though I don't think that a laser can really increase the chance that one of these nevi become melanoma, but still, here we have a problem now. Yeah?
One of them can be a melanoma. We don't
exactly.
know. Yeah.
We have a problem in the differential diagnosis. Are we sure that they are all nevi, or is there melanoma? We don't know. So this is a little bit the problem. So we should at least tell, we should avoid going with the laser on the lesions, So we have to try to avoid performing the laser removal on the nevi. Look how beautiful is this case, by the way. That's exactly what Nisa mentioned just a minute before. Sometimes when you do a shaving excision of a nevus, especially if the nevus is still very well pigmented, there could be a remaining part at the basis of the lesion, and this remaining part is becoming more and more prominent. So there is a new proliferation of melanocytes, which are actually looking like a melanoma. This is also called pseudomelanoma because histologically there are features reminding to melanoma. So this is a little bit, again, a kind of side effect of this technique of the shaving excision of dermal nevi.
Of course, again, here, let's repeat that, I mean, we're not trying to say that this is a biological, problem, but this is a diagnostic problem for sure, because at this moment, when you see what you show now in your screen, come on, how can you be so confident that this is just a recurrence of the nevus and nothing more?
And nothing else. Anyway, we have some clues helping us to understand if this could be just a recurrent nevus or a melanoma. And the fact is that usually, first of all, if this is a recurrent nevus should recur within the scar, not outside the scar. This is extremely important. And the other very important thing is that paradoxically, a recurrent nevus starts very soon after removing the nevus, while melanoma takes a little bit longer. And I will show you in a minute a case. So this nevus recurred in a few months. This nevus also recurred in a few months, by the way, within this kind of hypertrophic scar or keloid, because this is really too much for a hypertrophic scar. But look again how ugly it is. It's very, very ugly. But still, since it's within the scar, of course, we have to excise it. Now there is no question. We have to excise it. We have to do elliptical excision of this recurrence. And
in this scenario, even if you had the histopathologic of the previous nevus, in this particular scenario, maybe still, I mean, you would like to. Definitely. And just the last case here, it's a little bit easier to understand that this is a recurrent nevus. First of all, because you have remnants of adnexal so hair, which are still there, and you can still see a little bit the morphology of the pre-existing congenital nevus. But let me show you the last case. This is a lady we saw in 2019 with this very ugly looking lesion, and you can see that there is a scar in between. Very close to the lesion. But as you can see here, I'm not sure that this lesion is within the scar. In my opinion, this lesion is also going outside the scar. And we just realized that 4 years before, she removed a lesion which was diagnosed histopathologically as a dysplastic nevus. Okay, so definitely this is another recurrent nevus. This is a recurrent melanoma, and the lesion excised in 2015 was already a melanoma. And here you can see what I told you before. So the recurrency took 4 years to develop, and it's going outside the scar as respect to the previous cases of recurrent nevus. And that's it. So this is a very important topic in my view, and your cases, Nisa, were really outlining the main problem. The main problem is that whatever, the rule must be, it's forbidden that you have a piece of the body of someone and you trash it in the garbage. This should be forbidden. You know what I mean? So because
but the main problem is nowadays the British centers, even not doctors, not physicians, use laser. and they offer Nevi removal to the patients. So they don't know anything about a melanocytic lesion. This is the problem. I think we're going to see more and more cases, metastatic melanoma cases in the near future, because the usage of laser is increasing day by day.
Absolutely.
Yeah.
Absolutely. There are a couple of questions, several questions. First, hair removal lasers, we discussed about it. Then another question, non-pigmented dermal nevi on the face should also be sent to pathology? Yes, of course.
Yes.
Is
there scientific evidence or proof that laser can induce melanoma to pre-existing benign nevi? No, there is no evidence.
No. No, it's good that they ask it, because we need to clarify it and not get misunderstood by anybody. There is no evidence at all that any kind of procedure, laser or cryotherapy or whatever else you can imagine, can induce melanoma. The only thing that exists in the literature is some possible association between trauma and acral or nail melanoma, but again, this is not clearly demonstrated. The only thing which is demonstrated is concerning nail melanoma.
Yes, but it's demonstrated that a trauma can worsen the prognosis of a melanoma.
Nail melanoma.
Yes, but it's already a melanoma. It cannot, never, ever change the nature of a benign lesion into a malignant lesion.
Yeah.
But if you have a melanoma in the nail and you get a trauma, this melanoma can change its biology in a more advanced progressive tumor.
That's the only thing that exists as somehow evidence, and this is not clear cut. So no. Yeah, Nisa.
I agree with you, Aimilios. It's still a debate. We don't know laser induced or not. So we should be very careful with our procedures. The main problem is
Nisa, your connection unfortunately is not perfect. We lost you for a moment. We still don't have you.
I'm so sorry.
No.
Okay.
No, Nisa, it's not okay yet. So until Nisa's connection is back again, we continue maybe with the questions.
Yeah.
So, a very important question by Doriana, I think, or Lorena. Do you take pictures of those lesions that you decide to remove with laser? So I don't know, Geppi, if you would. I would respond as following. So without any question, we take always photographs of anything we excise. Concerning the ones we remove with laser, or we do cryotherapy, or we do whatever else, that's also a great idea. Look at the lesion I showed you before, the mama with the seborrheic keratosis. What's the problem? Isn't it better that I have the photograph, and in this moment that I have to do this dialogue, I can go back and check? So why not? Come on, why not taking a photograph of everything you are going to treat? But it's absolutely essential for lesions that you are going to excise, because you have diagnostic doubts. In this scenario, it's absolutely necessary, I would say. What would you recommend, Geppi, when nevi show these burn appearances, the ones you showed with the laser treatment? Follow up, I guess.
Yes, you have to wait. We have to wait. We don't have to do anything at the moment, because many of these lesions will become again normal, morphologically okay. For some of them who, again, instead got too much regression, too much inflammation, they're going to regress. If the regression is complete, then fine. If the regression is incomplete, maybe why not deciding to excise one of them just to make sure that, let's say, the differential diagnosis is, solved in some way. So far, but we have to wait. At the beginning, we have to wait.
Another question, should we avoid shaving a nevus? Well, no. Geppi said before that shaving in a dermal nevus is something that we do, given that we send the specimen for histopathologic examination. I think we have Nisa back.
Yes.
Yeah, I'm here.
Okay, great. So practically, another question, on which lesions can we use laser? Nisa, what do you say?
If you are sure about it's not a melanoma lesion, you can do it. For example, for freckles, if you are sure about it's a solar lentigo freckle, you can do it. But you should be very experienced with dermatoscopy. When you want, when taking a decision for laser, you should know dermatoscopy very well.
Yeah. For instance, let me give you an example. Irritated seborrheic keratosis, which are always challenging, although today we have investigated quite well the morphology, although we are able to recognize the majority of them, still, instead of performing laser, I prefer to shave and send the specimen for histopathologic exam, because, I mean, the degree of confidence is usually not absolute. There is a tiny doubt, and therefore, it's not a problem to shave and send it for histopathologic exam. Then, absolutely agree, photography before a destructive treatment is a good practice, gold standard. I fully agree.
There is also something in the question and answer. For melanoma patients, they could still proceed with laser epilation?
I was talking about this before my connection has failed.
Yeah.
I generally recommend for not to do hair removal with laser to the patients who have lots of nevi on the arms and legs, because we don't know. One of them can be a melanoma. So Geppi showed us very beautiful examples of destructed nevus with the laser light. So they can perform laser therapy only pubic area or axillary area if there is no melanocytic lesions there, not for the arms or legs. My recommendation.
Okay. But it's reasonable. You know, if there is a previous melanoma, it's better, to be cautious. Yeah. Also another one, it's nice. I see a nice thing. Last year, I reviewed a 24-year-old Italian with a lump on the groin. The lump was lymph node, I suppose, from a carcinoma. Upon examination, no concerning lesion. However, he confirmed in a trip in Napoli, he had a lesion chopped off. Oh my God. It was not me.
Come on, can you prove it that it was not you?
No, I cannot prove it.
Okay, great. Last thing, Nisa, before we let you go, we have a podcast also. Each week we show one of the 300 Ideas podcasts in order to remind the attendees that they are there, available, and they can watch them. And this time we will remind them one of your podcasts, which is one of the best ones we have there, because you did a very nice selection of challenging cases from the dermatoscopy blog. There are numerous challenging cases there. And of course, you present them in the podcast, you discuss the various diagnostic possibilities, and you give the solution.
Nisa, can you tell us just a short summary of the Ideas podcast? I mean, sorry, the Facebook discussion forum. Is it very active, interesting?
Yeah, in the Facebook dermatoscopy forum, there is already around 30,000 members. So they attend the discussions and give diagnosis, and it's very, very interesting and very funny dermatoscopy site. We learn together from the people all over the world, so we can see all types of skin types, dark skin types, light skin types. We can increase knowledge from the cases coming all around the world. So I really advise our friends to attend the Facebook dermatoscopy blog. And also we have an account on Instagram. We share cases there also, and with your explanations one day later. So for IDS forms, all these forms are IDS forms. We invite our colleagues to attend and learn together.
Exactly.
Very good. Very good.
Fun and learn together. This is our motto. Thank you, Nisa, so much for all your work, all the efforts for the society and in general for.
I thank you, Aimilios. It's a great honor and pleasure for me to be with you. I love you both, Geppi and Aimilios. You are great. Continue the good work.
Okay, Nisa, thank you very much for joining us this evening. Hope to see you very, very soon. And keep safe.
Okay. Bye-bye.
Bye-bye. Bye, Sean.
Bye-bye, Nisa. Thank you so much.
Ciao.
Okay, great discussion, great topic, great guest. And now the moment for the new stuff.
Yes,
exactly. The cases, some of the cases, come on, please excuse us, you understand that it's impossible within this short time to present everything, but we selected some of the cases you sent us, and quickly we will try now to present them. So I share again my screen, I select this file where I have included your cases, and here let's go one by one. First, 3 cases from Del Bar Mariel. Hi, Mariel, and thank you very much. The first one was a superficial spreading melanoma 0.3, a desmoplastic melanoma, the second 1 millimeter, and a spitz on a Nevus pilus.
Wow.
Okay, let's take a look. First, this is the 0.3 melanoma. Great catch, I would say, Mariel. It's not an easy one. In fact, it's not even easy to understand which one it is. I guess it's this one that I'm showing now with my mouse. Yeah.
Yes, probably is that one, and but it's definitely a great catch, because without dermoscopy, probably it couldn't be so simple.
Yeah. But even with dermoscopy, it's not an easy melanoma to diagnose. There are some irregular hyperpigmented areas here, but not very much. Let's say it's
probably she compared also with the other Nevi, and this one was looking different from the rest.
It was looking different, very possibly. This is the second one, desmoplastic melanoma. Geppi, take a look.
Yeah,
that's very interesting. With, this is of course difficult to recognize melanoma subtype, but we can see that there are globules which points towards a melanocytic tumor, because brown globules for sure correspond to melanocytic nests. And then the lesion is chaotic asymmetric with an intense white color in the upper part, probably corresponds to the desmoplastia. So a rare but very important to highlight subtype of melanoma. Thank you for sending us the case. And finally, this is maybe the most interesting, but for this one, Mariel, you didn't send us a dermatoscopic photograph, so I would like to see it, because that's really very strange. A Nevus pilus
with a spitz nevus inside,
and the spitz nevus inside. I was so curious to see how this spitz nevus looks like. So thank you, Mariel, very much. Next one, Gary. Hey, our friend Gary from South Africa. Hi, Gary, and thank you very much. Okay, here is your text. You sent us an eccrine poroma, which I will show you immediately. And then the second case was a 35-year-old lady with no previous melanoma history with a concerning lesion. Let's take a look. This is the poroma. I would say that the location is helpful. And also, do you see the cherry blossom, Geppi?
Well, I see this kind of flowers which are typical for ecrine poroma. Yeah.
It's although ecrine poroma might acquire several, might mimic anything. This is the most typical version of ecrine poroma, if we can say that ecrine poroma has a typical version. Very nice. And the second, this is the one that you don't still have the histopathology. You're asking about our opinion, which is, Geppi, our opinion?
Well, actually, what is concerning me is not too much dermoscopy, but the solitary nature of this lesion. If
Too lonely. Too lonely.
Too solitary, she feels alone. It's better to excise it. Yeah. So it's.
So if you were this lesion, would you like to continue living?
No. It's better to go in the bottle.
Yeah, so it's rather concerning. Yeah, and in dermoscopy, it's not. Yeah, okay. There are some worrisome signs. Okay, these irregular pigmented spots are a little bit worrisome. Very good. Then Hadaf Hassan, 25-year-old man, old cautery for tattoo removal, and then there is something at the margin of the scar, which is this one. We don't have the answer here. What do you think, Geppi? I would say BCC most probably.
BCC is my choice, yeah. But it's impressive, right? It's a very peculiar morphology. It's looking like part of the tattoo, which was, appearing by itself. A living tattoo.
Exactly. Okay, very good. Then the next one by Pascal. Hi, Pascal, and thank you very much. Dark node.
Alias Penelope.
Exactly.
She's the famous Penelope. Yeah.
Finally, we understand. We find out which is the famous Penelope who always scores first, second, third, always in the Kahoot game. Okay, great, Pascal. Thank you. So this is the lesion here, the clinical, and Pascal sent us also two very nice dermatoscopic images. One is with non-polarized light on the left and one with a polarized light on the right. I would say that in this scenario, the non-polarized light is more helpful. I guess that's a basal cell, a pigmented basal cell, but we don't have the answer yet. So
I would say that, of course, the differential is between nodular melanoma and BCC. But I agree with you. It could be, even though there is some black color, especially on top. Yeah, exactly there.
Yeah. But also here there is something like a spoke wheel area, I would say.
Yeah.
Yeah, and the vessels, I think that they are quite linear. Especially here that we can see them are quite linear. So I think most probably basal cell carcinoma, pigmented basal cell carcinoma. Let us know, by the way, it's an interesting case. Then Sid Rajinder Sidhu sending an image of a 47-year-old lady. That's the image you sent. That's, I would say, beautiful.
Beautiful. What a morphology. How old is the patient?
Unfortunately, she has to excise it. That's the problem.
70-something.
47.
47. Well, it's looking. Yeah, I mean, this is a schizoid-looking lesion, I would say. Yeah, so it must be excised. Yeah.
But in the age of 47, if I remember well, still the chances are by far for benign for Spitz nevus.
Yeah, definitely.
Okay, and then Shushanik Karapetian, 3 interesting lesions. So hi, dear colleagues, happy to have the chance. Thank you very much for your cases. 3 interesting lesions. First, on the nose, you say that the differential is sarcoidosis, lupus pernio, and other granulomatous disorders. I fully agree with this differential diagnosis. The vessels and the orange areas here, both of them suggestive of a granulomatous disorder. To the question if we can say which one,
no way.
I don't think so.
No way. It could be sarcoidosis. It could be even granulomatous rosacea. So the most simple differential, but definitely biopsy here is needed.
Concerning the second one, I am not sure if the image you sent corresponds precisely to this lesion, but in any case, I don't see anything in this image, just telangiectasia. So I don't see any signs either of lentigo maligna or of solar lentigo. So I don't know, Geppi, if you can say something for this.
No way.
Yeah. The third one is very interesting. It's on the glans penis. This is the dermoscopy. And your question, which is very reasonable, is Zoom valinitis, or should you think about Keira? I would say that based on the vascular, on the morphology of the vessels, that's much more compatible with Keira than Zoom valinitis, because the vessels are mainly dotted and glomerular. And this is rather for Keira. In Zoom valinitis, we would expect more linear vessels.
Yeah. But yeah, even though the lesion is very, very, very small, it could be also a kind of other inflammatory lesions like psoriasis or so. Yeah, probably it's not a Zoom, but another inflammatory condition is not excluded. Yeah,
sure. And the last one, because there is a special gift with this. So it's from Yazid Bourezan. Thanks a lot for your interesting appointment. I would like to hear your opinion on a Nevus, a plantar nevus that I will show. But Yazid also wrote for us, Geppi, for me and you, a poem entitled Argenziano and Lalas, and says, a duo with a big class playing football all their lives, like Ronaldo and Edson Arantes, Pelé, teaching dermoscopy for us. Thank you so much.
Thank you, Yazid. Wow.
Very sweet of you. Very kind of you.
This is super. Very nice.
Great. And this is the lesion of Yazid.
Okay. Nice.
It's nice. What's your feeling? I mean, dermatoscopically, it looks so perfect. It's a parallel furrow pattern. Yeah. And also, it's not an asymmetric lesion. In the center, there is a little bit of hyperpigmentation, but it's in the center.
What is a little bit disturbing is the size of the lesion.
Size. Yeah. Because the age is 47. I don't know. No, 38. So I really could not give a confident response here. Although dermoscopy favors a lot benignity, there is something annoying in the clinical morphology. So maybe follow-up would be a nice option in this scenario.
Yes, exactly. So since the surgery here must be performed only if there is a serious possibility of an atypical lesion, why not doing a 3 to 6 months short-term follow-up and check what's going on? If the lesion is completely stable, then this is reinforcing the possibility that this is just a nevus. But yeah, the size must be taken into consideration, because at this age, a nevus should be smaller, this is a little bit the point. And congenital nevus is the other option. So,
but we don't see what we would like to see for a congenital nevus. So it's the opposite. The eccrine openings are free of pigment instead of being pigmented. Yeah, so unfortunately we cannot help you very much, but
okay.
Good, that's it. I think that you also, Geppi, have...
Yes. I have a very nice collection from Bruno Brunetti from Salerno. It's very close to Napoli. I know Bruno since my entire professional life. We share a lot of nice things with Bruno, and these are the cases. So from Brown, Little Brown, because his name is Bruno Brunetti, which means Little Bruno. Okay, so this is the first case. Is the one I love so much. It's saying it's a patient going to him saying, "Doctor, I'm very concerned about my son because there are very brand new nevi appearing just a few days or weeks ago, and this is the situation on the clinical ground, and this is dermoscopy." What do you think about it, Emilio?
But the problem is that you didn't put your presentation in full screen, and so we see the next slide.
Yes. Okay, here we are, and that's the next slide. Yeah. So I suppose that Bruno was suggesting to the mama to change the chair, and maybe things will improve.
No, but I can tell you this has happened to me personally also. So I have this personal experience.
A personal experience about it. Very nice. Yeah. Okay. This is a very strange nevus observed casually in the context of a visit for atopic dermatitis. This is a little girl, and this is a quite worrisome lesion on clinical ground, and that's what we can see dermoscopically. And the point is that here the mama is not concerned at all. So she was going to Bruno just for the atopic dermatitis of the girl, but not for this lesion. Why?
Because she knows why this lesion is there. Probably.
Yes, she knows it. Yeah, she knows it. This was a kind of tattoo related to the, when little girls are fighting. It could be a very, very aggressive fight, So this is just a tattoo from a pencil. Okay, this is another strange nevus observed during a routine check. By the way, it's very, very strange, clinically and dermoscopically. It is so nice, yeah.
It's an ant.
It's an ant, yeah. The ant nevus. Very good, very good, very good, very nice. Okay. I'm sorry. What's going on here? I have a problem. Okay, so this is another lesion, but you saw already the dermoscopy. So clinical and dermoscopically, this is looking really like an external pigmentation.
The dermatoscopic image is not displayed well.
Yeah, exactly. Probably there is a problem. Okay, so painting from what? Whitewasher nevus. I don't know what's going on here. But anyway, he was doing something stupid with his leg, and that's it. Yeah. So grazie, Bruno. Thank you very much for your wonderful cases. And
thank you, Bruno, and all.
And thank you all really for sending us your cases. Please continue sending your cases because we will comment them all together. We are very happy to do it. And
we're very happy to do it. Of course, we apologize to those that we can't show everything, and especially when more and more will arrive, we will have to do a more strict selection. But we will try to show as much as possible because it's really great. So almost finished. Last thing, our usual Kahoot competition, our usual Kahoot game, which this week is very tough, Geppi.
Oh, really?
Sorry. It's very tough. It's very tough.
What should we do?
That's it. Come on. So, there are 5 cases as usually. Here is the pin, so please join. There are 5 cases as usually, 1 from each day of the previous week. For all of them, there are only 2 options diagnostically. So it sounds easier because it's 50-50. 2 options, okay? But 2 really tough options.
I see.
So, but in any case, you have 50% chance.
It's funny because there is a player called Argenziano. Hopefully, hopefully he will win. He or she will win.
Hopefully. As I did last week with Di Stefan, yeah. Okay. So let's wait a few more seconds. we will
By the way, while waiting, there are a few questions still remaining. If you remove a recurrent nevus treated with previous laser, are there specific histopathologic features in favor of trauma or not? Yes, there are, of course. Usually, the pathologist is able to make a differential between recurrent nevus and recurring melanoma, but sometimes could be very hard. So that's a little bit the point. Another one is: do you just laser the seborrheic keratosis when they completely when the criteria are completely met, or do you send all of them to the pathologist? No, of course, when the criteria of a seborrheic keratosis are clearly visible, so there are no doubts about the diagnosis, come on, we can do a physical treatment of any type. No, Emilio, do you agree?
Absolutely, of course.
Okay.
Yeah.
Very good. Okay, so I suppose we can go, Emilio. 123 people.
Let's go, because it's already, we are a little bit out of time, but it's okay. I guess it will be not more than 5 minutes. Let's start. Dermoscopy Happy Hour Kahoot Quiz, episode 8, 3, 2, 1. Monday case. So you don't vote yet? Wait a moment. So can you guess which are the two options?
Yes, of course.
Okay. So now we go to the next slide and then you vote. So obviously, the options here are
Nevus or seborrheic keratosis, of course.
Do you think it's an easy one?
No, it's not an easy one. It's not an easy one.
It's not an easy one.
No, not an easy one. Well, but my 5 cents go to.
You can
wait a moment. Nevus.
You see, correct, Nevus. But it was, come on, look.
Very hard.
It was very hard. So similarly, let's see the scoring. Kezia is another name that we very often see here in this top 5. Okay, Tuesday. Okay. Take a careful look. Of course, I know which is the impression that immediately comes to your mind. Okay. Good. Ready to go?
Of course.
Let's go. Tuesday case diagnosis.
2 options: basal cell or trichoepithelioma. This is an impossible one.
That's a really tough one. Yeah.
My 5 cents remain in my pocket.
Your 5 cents, you don't play, eh?
I don't guess.
But again, the majority were able to find it. Okay. Again, it was not there was a fight, but the majority were correct. Basal cell carcinoma with these white globules. That's a quite recently described thing. These white globules might be present in basal cell carcinoma. In trichoepithelioma, of course, white color is very frequent, but not usually in the form of globules.
Yeah.
If we can say something, okay. Good. And here, Kezia retains the first position. And Iride is C. Elichi, who was the winner last week, is again in the top 5. And and now we go to Wednesday case. Okay.
I can guess what are the 2 options.
You can guess what are the 2 options. Okay. So let's go to C. Ready to play in the Wednesday case?
No, it was easier. My 2 options were basal cell carcinoma versus squamous cell carcinoma. Here, it's much more difficult.
Yeah, of course, it's much more difficult. Yeah. But again, marginally, the winner is the winning answer is the correct answer. So invasive squamous cell carcinoma, because we see ulceration. Ulceration is a very important sign for invasive squamous cell. The white circles are a very strong sign for the differential diagnosis from basal cell carcinoma, from other things, but from actinic keratosis, it's not easy to differentiate the white circles from the
Show
white.
media.
What?
Show media. Click the button, show media. Yeah.
Yeah, okay, great.
Yeah.
I didn't know that I can do it. Thank you.
Yeah.
So these white circles are a very strong clue for if you want to compare with basal cell or with any other tumor. But with actinic keratosis, you see anyhow the follicles in actinic keratosis are white and somehow dilated. So it's not so easy. But the ulceration is definitely a clue for invasive tumors. Agree, Professore?
Agree completely.
Now, how can I close the media?
Click whatever you like. Yeah.
Okay, very good. And we go, we see the score.
Check them.
We say check them is leading now the ranking. And but we still have 2 cases to go. Let's go on Thursday. That's also tough. I am sure that you know which are the 2 options.
Keratocarcinoma versus well differentiated. Irritated seborrheic keratosis.
Yeah. Irritated seborrheic keratosis versus keratoacanthoma. That's, come on, it's not easy, is it?
No, it's not easy at all. And as you can imagine, you know where my 5 cents are going, you know?
I can imagine.
But now,
very good.
Yeah. Good.
Keratoacanthoma, but you see, in almost all the votings, there is more or less the similar percentage of the correct answer wins, but not with a huge.
Yeah.
Oh, very reasonable. Okay, again we have changes. Alla Dermo leads the ranking for the moment, and everything will be judged on Friday's case. Which I would say that it's rather the easier, but I'm not sure. I mean, I'm not sure how people will react and what they are going to vote. So that's the Friday case. Obviously, here we can guess which is our differential diagnosis. And let's see. It's a quite straightforward question. Nevus versus melanoma. Of course, you would like to ask for the age and so on, but don't.
Based on what you are showing, my 5 cents go to Nevus.
Yes, and this was in fact the easiest, as we can see from the result. Very good, excellent. Ready to see the podium?
Ready to see it.
Number 3. Bernie, Colombia. Bravo, Bernie. Number 2. Lentaigo maligna. Very good. Number 1. Alla Dermo. Very good. Alla Dermo.
Beautiful.
We want to see Alla Dermo.
We want to see Alla Dermo. Please join us. We have to congratulate. If you are able, if you are not in the pajama, if you are able to open your camera. Otherwise.
Okay, let's remind the basic things.
Yes.
YouTube channel. You can find this episode and all the other episodes on our channel on YouTube, so please subscribe. What else, Geppi? Send us your cases.
Because we will more and more comment, dedicate time to your cases. Alla Dermo is here.
Hi, Alla.
Hello.
How are you?
Fine,
Congratulations.
thank you.
Very nice.
I am dermatology resident from Iraq.
From Iraq.
Great.
Where are you based?
In Iraq, Nasiriyah city.
Nasiriyah, okay.
Where there is the ancient city of Ur.
Yes, and where I suppose the Italians were there for a long time, I suppose.
Yes. During the invasion, there were Italian forces.
Yeah. Very nice that you had time to join us, and very good job. Very good job.
We are very grateful for you and your efforts.
Thank you very much. Thank you. We are very honored.
Thank you so much.
Thank you, Allah. Warm congratulations.
Dear Dr. Aimilios, the case from Sir Professor Hadaf Hassan, which was you diagnosed by dermoscopy as BCC, the histopath came back as TB granuloma, which was very surprising to us. Because
you mean the one on the tattoo, the one close to the tattoo?
Yes, the one on the tattoo. The histopathology that it is a TB granuloma, tuberculosis granuloma.
I see.
But by dermoscopy, we see it as hairpin vessel, and we diagnose it by dermoscopy as SCC.
I see. Yeah, but that's very good feedback. So it was a tuberculosis.
Yes, tuberculosis is very common in Iraq, and it could be an implantation from cautery.
Mm-hmm.
Great.
Very good.
Great. Thanks for the feedback, Allah.
Thank you so
very much.
Thank you.
Take care.
Thank you so much.
Thank you.
Bene, ragazzi.
Because I have to say that I enjoyed very much this episode.
I liked it very much, even though I had a little bit of sad feelings because of what I told you at the beginning, but staying with you was, let's say, relieving my soul. And okay, so we wait for you for next Sunday, 7 p.m. chat. And Emilio, ciao. I will miss you.
1 week is too long, we said.
Ciao, Seppi. Ciao. Ciao, Nisa. Ciao.
Thank you all. Thank you, Nisa. Thank you very much, Nisa. Bye-bye.
Thank you.